So I'm going to talk a bit about diabetes in cystic fibrosis, and we're not quite at the exciting stage, I don't think, that we just saw in that last talk, which was news to me and incredibly exciting. And but hopefully when I come back in a year or so, we'll be at that same place where I'm going to tell you, here's the cure. We give you this pill and it's going to cure this problem. But so I don't have a slide changer. I just have a laser, I think. So do I laser you every time I do this? So I'm going to give credit. So as Dr. Cairns mentioned, there was a conference that I unfortunately wasn't able to attend that Dr. Bremer, who's a pediatric endocrinologist from Vanderbilt, presented. And so some of their slides from that talk I'm going to have taken because it's the newest and greatest. Go back up there yet. Wait. And the way you'll know is because they're going to have this blue background. So I figure I'm giving credit where credit is due. So next. So you've all heard of diabetes, and actually since many of you are familiar with cystic fibrosis, you've heard about cystic fibrosis related diabetes too. In fact, let me get an idea, because I haven't presented here, or if I have, it was a decade ago. So who here has CF or has a family member who has CF? Raise your hand. Okay, so that's the crowd I'm talking to. Good. That's what I thought, just to make sure. So type 1 diabetes, I'm a pediatric endocrinologist, so I deal only with kids, although I have some CF patients into their mid-20s, although less now that the adult diabetes docs are getting more comfortable taking care of this. So there's 3 types of diabetes. In pediatrics, we generally deal with type 1 diabetes, which is an autoimmune disease where you destroy the cells that make insulin, and therefore you're insulin deficient, as opposed to type 2 diabetes, which is the classic one in adults and what we classically think is associated to being overweight. That's a problem primarily where insulin is made. However, it doesn't work very well in the body, so you're insulin resistant. And then we have CFRD. And so this gives you a comparison there. I guess I could mention also, I do have some handouts that have the PowerPoint talks here. So if people at the end have a great desire to get some of the specifics, you could see me, and I may be able to put it on the website as well. I don't know what this website thing is, but probably willing to do that. So if you can't see some of the details, that's there. But in a nutshell, CFRD, the patients tend to be thin as opposed to normal weight or overweight. It's not an autoimmune etiology, meaning it's not from your immune system. It's related to the cystic fibrosis defect. They generally don't have ketoacidosis, which is the way that type 1 children present, where they're really sick with no insulin and it's a life-threatening presentation. That's not how children with CFRD present. As we're going to talk about, it does turn out, unfortunately, or fortunately because individuals with cystic fibrosis are living much longer now, they're living long enough to develop the complications that we knew were common in patients with diabetes, what are called the microvascular complications. And that does develop in cystic fibrosis-related diabetes. But fortunately, we're getting more and more evidence that says the macrovascular complications, which is like the heart disease, which leads to a lot of mortality in adult-type diabetes, doesn't seem to develop in this population. So it's a very common problem. Numbers are varying, and most of this is probably selection bias. As we learn more about it and screen for it more, we're finding that it's more and more prevalent. So it's not clear that the prevalence is actually increasing as much as we're getting better at detecting it and detecting it earlier. It's about 20% of adolescents and about 50% of adults will have or develop cystic fibrosis-related diabetes. We know there's increasing data that it's associated with a worse overall survival rate, which is why we're doing more and more research in the area. As far as the cause of it, it's really a combination of 2 things. I'm going to mention the second one first, which is insulin resistance, which is sort of like the type 2 diabetes picture. In part, that's related to infection. Frequent infections make you resistant to insulin. It also turns out there may be some molecular defect related to the CFTR gene that also alters insulin resistance a little, but that's not the major component. The major component is actually fibrotic pancreatic destruction. And what that means, the next slide, shows you here sort of, if you look here, this is a pancreas. And remember the original name for this disease, it still may be caused, is cystic fibrosis of the pancreas. So that is the initial description of this disease, is, even though the lung disease is what I certainly think of when I think of cystic fibrosis, it's originally a disease of the pancreas. And in a normal pancreas, the vast majority of the pancreas are these cells related to making the digestive enzymes. I'm an endocrinologist. They don't mean anything to me. What I deal with are these little, what are called islets of Langerhans. These are little islands that sit in the pancreas, and here's an example of a slide of a pancreas. All this tissue around here is the exocrine, that is the part of the pancreas that makes the digestive hormones. And these little islands, which is a small percentage of the pancreas, are where the hormone parts of the pancreas are. And they're really completely unrelated once they've developed. They develop from the same place, but totally different function. This is an endocrine system as opposed to a digestive system. And what happens in cystic fibrosis, here's a picture of a pancreas in cystic fibrosis. You get destruction of all the architecture related to the primary disease, and the beta cells, it appears, tend to just get caught up in all that destruction, and they disappear in number. So you actually lose the ability. Whereas in type 1 diabetes from childhood, you actually attack just those cells that make insulin and destroy them. So if you were to look at the pancreas in a type 1 diabetic, the pancreas looks totally normal when you first look at it. You'd have to get down to the molecular level or the cellular level to actually see any destruction at all. So it's a very different disease process than we see generally in kids with type 1 diabetes. So here's a graph or a picture to sort of show you what happens over time, and then we'll talk about the individual periods. So this is beta cell function, and beta cells are the cells in the islets that make insulin. So beta cell function correlates with insulin production, and this is age. And you start with a normal rate of beta cell production and insulin production, and you decline over years. And at some point, you get to a level that's low enough that you have what's called impaired glucose tolerance. Impaired glucose tolerance is when you eat a meal, you don't deal with the sugar that comes from that meal quite as well as you're supposed to. Meaning, for example, you just had your meal here, and normally your blood sugar would never go over 200 after that. Someone with impaired glucose tolerance may briefly shoot up to like 250 and then rapidly come back down to the normal range. That would be one type of impaired glucose tolerance. Or it could be that maybe your blood sugar is just a little higher in the morning when you wake up than it's supposed to be. And we'll look at some specifics. So that's sort of the impaired range where you're making insulin, but you're just not making enough insulin. Or what happens in this period, you're not making quite enough insulin to overcome the resistance that might develop. So often what happens in children with cystic fibrosis is they're going along, they're here, they're fine, they're totally asymptomatic, blood sugars are normal, whatever, and then they get a pulmonary infection and they get sick. Or they get put on steroids. Okay, steroids make you resistant to insulin. So, and in fact, part of the reason you get resistant when you have an infection is because your body makes its own steroids. So you get on steroids or you're making steroids, and now that little bit of insulin that was doing just fine for you, it doesn't change, but it's not enough insulin to overcome that resistance that you have. So now you start having problems with blood sugars. Okay, so now your blood sugar starts shooting up out of the normal range, even though you really haven't changed anything other than the situation in which your pancreas is trying to work. And then you ultimately get to a point where you don't make enough insulin at all, that you have classic diabetes. So how do we define this? So here's the classic categories, and I wouldn't worry about the specific numbers. We could deal with that in the hospital when we're trying to make a diagnosis, but more the categories. So you could have normal glucose tolerance, which means a fasting blood sugar that's less than 126. And an OGTT. So an OGTT, most of you are probably familiar with, is where they give you that yucky sugar stuff that's orange or whatever flavor it is. Anyone who's been pregnant has had that, where you take it and you do your glucose tolerance test during a, pregnancy, and you feel nauseous, and they check your blood sugar an hour or 2 hours later. That's an oral glucose tolerance test. And one can define diabetes by what your blood sugar does 2 hours after taking that glucose slush. And so normal would be that you should be less than 140 at 2 hours. Impaired glucose tolerance is either an abnormal fasting, not up to 126, which is diagnostic of diabetes, but between 100 and 125. And then an oral glucose tolerance test that isn't abnormal, which would be over 200, but isn't normal, which would be less than 140. So that's impaired. And then you can have cystic fibrosis-related diabetes. And we still have two categories, although that may not be for long because it's not clear the treatment for those two different categories really needs to be different. But we generally have a category called CFRD without fasting hyperglycemia, meaning that your fasting blood sugar when you wake up in the morning is less than 126, or CFRD with fasting hyperglycemia, meaning that your fasting blood sugar when you wake up in the morning is over 126. Okay, so there's the criteria, and actually there's a little new one that's been added, which was just presented at this recent meeting, of this indeterminate glucose tolerance. So let me just go through this again. So here's your glucose values over here. This is the oral glucose tolerance test at 0, 60, and 120 minutes. In all the situations, so in CFRD with fasting hypoglycemia, you start high, you end high. That's diabetes. That's an easy one. In cystic fibrosis without fasting hypoglycemia, you start the study, your blood sugar is normal, but as soon as you give any glucose, your blood sugar is over 200 and stays over 200. In impaired glucose tolerance, you start out normal, you go up abnormal, and then you drop down into an intermediate range. And now this indeterminate one, you start normal, you go up to the abnormal range, a little abnormal, and you're back down to the normal range. And this is one that we're still learning more about. Many of these patients go into, have normal glucose tolerance tests on repeat evaluation. So it's not clear the clinical significance at this point. And then, I'm sorry, that was the indeterminate one there. And then the normal glucose tolerance is here, where you could go up to 150, 160, but by 2 hours, you're normal. So there's the different categories we could have of impaired glucose tolerance in diabetes. So how common is this? Here's data from 2008. This is looking at 237 individuals, and here's what we see. Greater than 20% by age 15 will have diabetes, 45% by 20, and 70% by age 30. Impaired glucose tolerance is obviously more frequent because you go through a period of impaired glucose tolerance before you actually have diabetes. So 20% by 10 years of age, 50 by 15, and 75 and 80 by 30 years of age. So we're certainly not talking about a rare condition. This is the rule and not the exception in cystic fibrosis. So Tony Moran is actually a friend of mine who's in Minnesota. She was a pediatric endocrinologist. We were fellows at the same time. And she's gone on really to take a passion and a love for, I mean, her heart is in cystic fibrosis related diabetes. And I see her at the meetings every year, and this is what she does. I mean, she also runs a program, and she's a great general endocrinologist, but her passion is diabetes in cystic fibrosis. And she has published the brunt of the material that's on there. And this is one of her studies from her group at University of Minnesota. And this is another way to sort of look at the prevalence. And this is looking, the dark bars are the overall incidence. And this is just so you can sort of see a pictorial rate rather than with numbers. Obviously, the older you get, the more common it is. And we can see that fasting hyperglycemia with it seems to be more common than without it as you get older. And as we'll talk about, that's the disease that tends to be more associated with the microvascular complications. That's more like classic diabetes. So not only are we worrying about nutrition and stuff, which we'll come to, but we're worried about, well, you have diabetes, what does high blood sugars do to your body? This is also interesting and may come into play from more information from the previous talk. This is looking at what's the role that the actual molecular defect plays. In other words, so here's looking at the delta 508, the most common mutation in cystic fibrosis. It turns out that if you have, so heterozygote means that you got one of those gene mutations from a parent. Homozygote means that you got it from both parents. So it's a double hit. And it looks like you can see that the incidence of diabetes is proportionate to how likely you are to have that mutation. So what this tells us is that, and there's more evidence to show this, that actually the molecular mutation is playing a role in insulin secretion and how diabetes develops. So it's not just the external environment and the destruction of the pancreas, but there's actually an inherent problem in the beta cell as well related to the mutation. So, in summary of what we've gone over, here's your clinical spectrum. You could have normal or indeterminate or impaired glucose tolerance, and these patients clinically look fine. And then you start having impaired glucose tolerance or cystic fibrosis-related diabetes, and these patients don't look as fine. And there's clear data to show alterations in pulmonary function that's clearly associated with impaired glucose tolerance and cystic fibrosis-related diabetes. So it clearly correlates with lung function. So he had his stories, so I'm going to have some of my stories. So this is the start. I'm going to do it locally. This is Acadia, and this is from Acadia looking into the ocean, and that will develop a little as we go along there. So the importance of early identification. Why do we care? Why are we putting kids through these miserable screening tests earlier rather than just waiting till they have overt symptoms of diabetes? Well, as I just alluded to, it has a negative impact on pulmonary function. CFRD leads to poor weight gain and worse overall nutrition, and that's not surprising. It turns out that insulin is actually a really important hormone and a really good hormone. People often think of when they have diabetes, oh, I don't want to take too much insulin. You know, I want to try to decrease my carbs because I don't want to get too much insulin. And in fact, absolutely not the case. What you want is insulin. Insulin's a growth hormone. It's an anabolic hormone. It's the most important anabolic hormone in the body. It helps build muscle. It helps keep your electrolytes and your liver and everything happy. So it's a good hormone. And when you don't have it, you're catabolic. That means you're breaking down muscle mass. And so part of the problem of being deficient in insulin is not only when you see it that you're deficient enough that your blood sugar is high, but even before that point, you're deficient in insulin, and so you're not building up muscle as much as you should be. And in fact, you could be losing muscle related to that. And that's probably why CFRD has a major negative impact on survival. And interestingly and concerning, and why we're doing the screening, is all of these problems with insulin deficiency seem to actually be developing before you actually have cystic fibrosis-related diabetes. So it's important to follow the progression of that over time. And then there's diabetes. This is data that unfortunately you probably all know, or it's in the news all the time. It's why whenever the president speaks about health care or anyone talks about health care, diabetes is always the #1 topic mentioned. About 1 in every 7 healthcare dollars in this country is spent on the complications of diabetes. And the management of diabetes. So it's an incredibly expensive disease. And the reason it's so expensive is not as much for us to take care of the blood sugars, but dealing with these complications of diabetes. So these are the microvascular complications of diabetes. Over here for type 1 and type 2 diabetics, it's a similar incidence. And you can see eye disease, it's the leading cause of blindness in this country, is greater than 50%. Nephropathy, kidney disease, and renal failure, renal transplants, it's the leading cause. And we're talking not CFRD, we're talking diabetes as a whole here, of which, remember, 95% of diabetics are type 2 diabetics. So we're talking primarily about the adult type when we're talking about the statistics, just because that's by far the most common diabetes. Neuropathy, which is what leads to the amputations. And gastropathy, which is part of a neuropathy, part of a nerve condition that leads to inappropriate constrictions of your stomach and intestines so that you don't digest food appropriately. So what you can see is it's less common in CFRD for at least the first two, but probably as common for the latter. And again, macrovascular disease, which is a major killer in diabetes, fortunately, from the CF perspective, does not appear to play a role, probably related to the fact that you're thin and the body habitus doesn't have the lipid issues that is seen in type 2 diabetes. So this is a survival curve, which are always spooky for me to show, but I think relevant. So this is looking at overall patient survival. This is from a pediatric journal published in 2008. And the two different curves here are the dotted lines here are patients who are over 18, who were diagnosed with diabetes after 18 years of age, and here diagnosed with diabetes before 18 years of age. And so the farther you get down on this curve, the less percent survivors there are overall. And what you can see is certainly you drop off sooner and to a much farther point if you've had diabetes than if you don't. This is at age 18, and this is looking at impaired glucose tolerance in a population, whether you developed it before or after age 15. So it's suggesting that the development of this leads to a much poorer outcome. But I'm going to tell you, we think this could change by picking it up early and treating. So this is not inevitable, and that's why we're doing this talk, and that's why we want people to be aware. In fact, here's looking what's gone on over since 1992 to 2008. So let's first focus on the bottom slide here. The solid lines are patients with CFRD, and the flat lines are no diabetes, and this is mortality. So clearly 15, 25, 35, 45 years mortality is much higher in the patients who had diabetes than didn't. If we look at 1998 to 2002, we see they're a little closer. And if we look at 2003 to 2008, we can see that up to 30 years of age, that almost they're approaching each other, that the mortality now with our intervention and what we do with diabetes now in our patients shows that the mortality rate that used to be very discrepant is now approaching. And hopefully what we're going to see is that there will be no difference as long as we pick it up and treat it. So to summarize, there's clear evidence that early identification of CFRD impacts health status. Delaying the diagnosis leads to unnecessary deterioration. And several studies have shown that long-standing deterioration and an insidious decline in the clinical status will be present even before we make the diagnosis of CFRD, and thus our efforts to try to get us to make that diagnosis earlier. So now we've moved into the park, and I think this is Little Round Pound. I can't remember if it's Round Pond or Little Round Pound. Anyone know? Oh. But anyway, okay, next. So what are the potential symptoms of CFRD? Well, unfortunately, the vast majority of patients don't have any symptoms. So if you start having blood sugars over 180, you start spilling sugar into your urine. When you spill sugar into your urine, the sugar acts like a sponge and pulls water with the sugar, and it makes you pee a lot. So the classic symptom of diabetes is you start drinking a lot and peeing a lot. Okay? Now that happens when your blood sugar is over 180, but as we were talking about, these kids are having issues when their blood sugars are 140 to 180 as well. And that you're not going to pick up with by symptoms. So polyuria polydipsia is a concern, but may not be your first symptoms. The same thing with weight gain and poor growth and poor pubertal development, all related to poor nutrition associated with lack of insulin, because insulin is the most important growth hormone in the body. And then if you have unexplained pulmonary function decreases and you don't have an explanation, thinking about glucose metabolism is something that you want to do. So what are the current recommendations for screening? Oral glucose tolerance tests should be done annually starting at 10 years of age. And this center does it, and I'd say I go to national meetings every year, and we were doing it long before most centers in this country were doing it. I think in part because of our ties with Dr. Moran in Minnesota and her coming and talking and whatever. But we've been ahead of the game on this all along, right up there with Minnesota. So we've done a good job with that. Fasting and 2-hour postprandial blood sugars during hospitalization. So a hospitalization is sort of like a glucose tolerance test. Rather than giving glucose, what we're either doing is giving them steroids, or we're telling them to be, not telling them, but they're sick. And when they're sick, they're stressing their body and making their own sugar. Their liver's making more sugar. They're making more hormones that make sugar. So in a sense, you're doing a poor man's glucose tolerance test. And that's why if we look at their numbers when they're in the hospital, that could often be our earliest signs. And so that's when I often come and first meet the families, and it's always a tough situation because it's like, no, you don't have diabetes, but here's our concerns, and we don't know perfectly yet what to do about this, and we don't know perfectly how an individual is going to follow from the first time where they have a high blood sugar, whether they're going to have diabetes in a day, a week, a month, or a year, and everyone seems to be different. But that's information we're trying to get better at predicting who is it most important to start treatment on earlier. One of the newer areas where we're also using to make a diagnosis of diabetes, certainly in the non-CF world, is related to glycohemoglobin, or hemoglobin A1C. And since it's mostly adults here, many of you have probably heard about that because doctors are now screening their primary care offices. Next. So just for those of you who don't know what hemoglobin A1C is, so hemoglobin is the protein that's in your blood that carries oxygen around. And it lasts about 2 to 3 months. Well, it turns out that whatever sugar is in your blood irreversibly binds to hemoglobin. So the longer the hemoglobin is around, the more sugar will attach to the molecule. And the higher the concentration of sugar while that hemoglobin is circulating in your blood, the more sugar will attach to that molecule. So what we can do is we can measure how much sugar is attached to the hemoglobin molecule. And since the blood cells have been around 2 to 3 months, that will tell us what the average blood sugar has been over the 2 to 3 month life of the hemoglobin molecule. And in general for diabetes, that's a very good correlate to us for whether or not you have diabetes and whether or not you're at risk for developing the microvascular complications of diabetes. It's not as true necessarily in cystic fibrosis because you may have other issues that are going on that alter the life of the hemoglobin molecule. So if hemoglobin isn't lasting as long because you have an anemia or you're breaking it down, well then obviously not as much sugar is going to get attached to it. So it turns out that changes what we call in medicine or in statistics the sensitivity and specificity. So the sensitivity for the hemoglobin A1C turns out not to be very good, meaning it could be low and you could have diabetes. But the specificity is still very good, meaning if you have a hemoglobin A1C over 6.4%, that's diabetes. In other words, there's no way you're going to get up to that value without having diabetes. And that's true for the CF patient as well as the non-CF patient. So, and then you could actually correlate what your hemoglobin A1C is with what your average blood sugar has been over the last 2 to 3 months, assuming your hemoglobin is lasting an average amount of time. Okay, so let's talk about some newer things, some things that are changing. So, continuous glucose sensors. We use them in our patients with diabetes to help adjust blood sugars. But there's some studies coming out in the cystic fibrosis population that says maybe this is the way that we could actually make an earlier diagnosis. So what is the glucose sensor? What the glucose sensor is either like this is the Medtronic one. You have this little thing that's about the size of a quarter, thickness of 3/4, size of a quarter. Put it on your skin, and it transmits every 5 minutes a blood sugar to, in this case, it's an insulin pump, but it could transmit it also. Here's a little girl wearing the one that goes with the Dexcom. And you can see that you actually get a plot on the machine of what your blood sugars are. Or you could download it onto a computer and see what your blood sugars are. So with this, what we can do is you could have a patient come in, we could put them on this for 24 hours or 2 days or 3 days, and we could actually see what their blood sugars are doing over the course of the day. And this may be a better way of picking up very early abnormalities in what happens after a meal, for example. So let's say your blood sugar shoots up after you have pizza to 230, but when you have hot dogs, it only goes up to 120. You know, this is something where you could actually learn some more specifics about, maybe we need to look further to see if we're having abnormal glucose tolerance tests. So this could, at this point, be a screening to say, should we do glucose tolerance tests? Or this may actually turn out to be a better test as we get more information about it. But that's the glucose sensor. Here was a study actually done in 2008 looking at using the sensor and showing that it was helpful. And in fact, the consensus guidelines from the International Society of Pediatric Diabetes suggests that we start considering using this for the evaluation of impaired glucose tolerance in cystic fibrosis-related diabetes. Okay, so now we're in Round Pond, and this is someone who came to visit us. I was there with my daughter and my dog, and I think it's a beaver. I don't know. I don't know an otter from a beaver. Since everything's called beaver this, or oh no, there's otter this and otter that at Acadia too. So maybe an otter. Is it a beaver? Thank you. Okay, it's a beaver. So she wants me to move on. Okay, enough with the beaver. Just like my wife at home, I tell you. Okay, so now we want to manage CFRD. How do we do that? And I'll be pretty brief on this because we'll be teaching you how to manage this if you need to manage it. But you want to control blood sugars. You want to avoid serious low blood sugars because your brain needs sugar just like it needs oxygen. In fact, the only reason your brain needs oxygen is to burn sugar. So if you have no sugar, it's just like having no oxygen. And people generally understand what it's like to have no oxygen. You know, you can't go 4 minutes without oxygen, and you can't go 4 minutes without sugar. Okay, so a very low blood sugar is very dangerous, and in fact, the most important part of early education for our families of kids with diabetes is once we're giving them insulin, they have a risk of a serious low, and we need to teach them about how to recognize and treat low blood sugars. It's a different population, and I'm learning every time I have a new family with cystic fibrosis-related diabetes how to manage it. Because I've been managing kids with diabetes for 25 years. More than that. But I've been doing cystic fibrosis children with diabetes probably for 20 years, but with an increasing number. And it's a different population, as you guys probably know better than I know. You already have one chronic disease, and now you're adding another chronic disease, and it's tough. So learning how to be flexible and how to deal with a population that needs to gain weight rather than lose weight is a learning experience for diabetes teams, but we're learning it better. And it requires a big team. This is not the doctor's issue. In fact, once someone's diagnosed, I can honestly say that I do less than 20% of the care that's provided for these patients. It's all the dietitians, the certified diabetes educators, the nurses who work there, the nurses who communicate with the pulmonary nurses, or the nurse practitioners who you guys all know, and on and on and on. And then at the end there, we have the docs who are involved as well. And the psychosocial support is critical. We require for all our diabetics, regardless of type, to be involved with psychosocial care. And that's whether they have cystic fibrosis or not. So you add cystic fibrosis on top of it, and it's really critical. This is a family disease in childhood. Anyone who has a child with diabetes knows that this is always there and ever present. Every time you eat a meal, you have to be thinking about diabetes. In a sense, it's more ever present than the CF disease, where you could spend a weekend and not think about it. The diabetes, once you have it, you can't spend 6 hours without thinking about it, which is stressful, to say the least. And then our goal is, again, to try to improve nutritional status, because we know that's correlated with overall health. So how do we do it? Blood sugars. Check a lot of blood sugars. You know, patients who have diabetes already, we request that they check at least 6 and generally 6 to 10 blood sugars a day. Similar targets to what we use with our type 1 diabetics. Oral hypoglycemic agents, as much as we'd love to say that's the future, it isn't. All the evidence points to insulin as the drug that's needed. So these patients are like the type 1 diabetics. They're not like the adults in type 2. Oral agents do not appear to help. And that's not totally surprising, because what these patients need is insulin. It's not like the type 2 where they have tons of insulin around, it's just not working. These patients are deficient in insulin, and we need to give them insulin. And unfortunately, at this point in time, the only way we can give any protein is not by the mouth, because any protein you give by the mouth, your belly digests it and makes it into amino acids, and then it doesn't work. So any protein we give has to be by an injection at this point, or inhaled, or something of that sort. So oral agents are not options at this point, although we're certainly working on them. So how do you manage diabetes? Well, diabetes is a balancing act, to put it mildly. And so food we have some control over. That's good. So of course in CF, carb loading is the standard. I don't know how that's genetically programmed or habit programmed or whatever, but carbohydrate intake seems to be the gold standard, and so we have to learn to try to minimize at least the simple carbs to try to get the complex carbs to try to match its work with insulin. But food is important, and we can't control it. Activity, the more the better. And that's true for any form of diabetes, because the more active you are, the more sensitive your tissue becomes to insulin. And the more sensitive it is, the better off that insulin will work, and the better you'll gain weight. Insulin, we'll talk about. Stress, we already talked about. Reducing stress is important. Stress increases those counter-regulatory hormones, the hormones that raise blood sugar and make it tough to control diabetes. So just in brief, how do we manage diabetes? We do it now generally with the basal bolus concept, which is that you have 2 types of insulin that you need. If you look down here, you have the insulin that's made all day long, and that insulin is because our liver is always making sugar. If our liver wasn't always making sugar, we could never go 2 hours without eating, because our brain always needs sugar, right? And if we absorb all our sugar within 2 hours, there'd be no sugar left and the brain wouldn't function. So somewhere sugar has to come from all the time, and it comes from the liver. The liver's always making sugar in anyone, or you couldn't survive. So this basal insulin, the insulin that we give in a long term here, a low dose that's pretty constant over the day, that's to deal with the sugar that the liver is making all the time. And then on top of that, every time you eat a meal, you need to take insulin to cover the carbohydrates that you're eating. Or if your blood sugar's high because you're stressed or whatever, you need to take insulin to bring it back down to your target range. So those are the 2 types of insulin that we have. And fortunately, carbohydrate counting's gotten a lot easier because of the mandatory requirements of labels. And so everything will have on it, anything that you purchase, and any fast food, they have to be able to give you access to that too, and most of it's online. And you could find out how many carbohydrates are in some food, and what you'll get when we give you a regimen is you say, okay, for every 15 grams of carbohydrate, this is how much insulin you need. And this is what the patients are taught and learn when they come to the diabetes center for how to manage this. So, insulin. There's a whole bunch of insulins out there. Major point here is there's quick-acting ones and long-acting ones. And we'll pick a quick-acting one and a long-acting one that works best with whatever we need to be managing. And in cystic fibrosis, many patients are on feeds through the night, so often we'll combine like 3 different types of insulin. Or more and more of our patients are getting on insulin pumps, which we'll talk about. So in general, our concept for how we want to manage, if you look at the shaded area here, the gray, that's how your own pancreas would make insulin normally if you were to eat 3 meals during the day. You'd have some insulin around, you'd spike with your meal. In fact, you start making insulin as soon as you see and smell a meal. Okay? So you don't even have to put food into your mouth, and your body's already making insulin. And that's key, and that's why we try to get our patients who have diabetes to take their insulin before they eat, because that's what happens normally, is that insulin's made before you eat. Okay? And then you can see, so back to the gray shaded, there's lunch, there's dinner, and then a little bit of insulin that your pancreas is making during the day. So our goal is to take all these different insulins we have and try to mimic that effect as best as we can. And these are just different types of quick-acting insulins or long-acting insulins that we can use to do that. To make it easier, technology has been advancing and making all this easier. We now have pens available with both the long-acting insulins and the short-acting insulins. The sizes of the needles and the thickness of the needles have gone down to, I would say that most adults, when I put one of these needles in, and I do it to every new adult that has a kid with diabetes, none of them will say it hurts, and some of them can't even feel it. So the discomfort of these needles is not painful. In fact, the finger pricks are clearly more painful now than the insulin injections are. Okay, so we've moved along, and this was one of my companions, my dog Yofi, and so she was taking lessons here from the little beaver. She's a golden non-retriever, so she wouldn't go chasing anything and nothing, not a ball, not an animal, nothing. She sits and watches. So she'll retrieve food from your hand, no problem, or anywhere else it is, but she won't bring it back to you. Insulin pump therapy. So I would say about half of our diabetics now we manage with pumps, and I'd say probably about half the patients with cystic fibrosis-related diabetes we're managing with pump therapy as well. And there's all sorts of pumps on the market. They all work with the same concept, which is they have a syringe inside with a little screw drive that delivers insulin, and they have a catheter that sits on their skin where there's a little plastic catheter that sits right under in the subcutaneous space and delivers insulin. They all need to be changed their sites every 2 to 3 days. And there's little different things. Like there's one that's completely contained that you stick on your body. There's other ones that have pump meters and whatever. And they're advancing further. Now what they tend to have is they have associated components. For example, the Medtronic pump has this continuous sensor. So you could put a continuous sensor on you, and it, through radio waves, sends the continuous blood sugars to the pump. The pump will show you what your blood sugars are. And anytime you want, you could say, okay, I'm going to eat 45 grams of food. So you put in 45 grams of food. It says your blood sugar is 160. I say, oh, okay, my blood sugar is 160. And then you hit activate, and it will do this little calculation. It will say, here's what your food is. Here's how much insulin's on board from what you've taken in the last 3 or 4 hours. Here's how much you're eating, and here's how much insulin you need for what you're eating, because you've programmed that all in. How much insulin you need for how many grams of carbohydrate. And so pretty much you put in your grams of carbohydrate and hit activate, and it says this is how much insulin, and you hit go. And so it's about a 3-second process where it will calculate the amount of insulin you need. So that's insulin pump therapy. And these sensors are feeding to fancier and fancier devices all the time, like iPads and iPod touches, and even your car. So here's a car that actually was at one of the diabetes shows, where this Oldsmobile had their Dexcom meter, their Medtronic meter, giving them a constant blood sugar while they're driving, which is actually useful because you like to know if your blood sugar is low while you're driving. So interesting stuff. Okay, so CFRD management, continued nutrition. You want to get calories. You need to maintain calories because the goal is to get your BMI greater than the 50th percentile, because that's associated with much better pulmonary outcomes and overall outcomes in CF. We talked about this. Screening for complications. This comes back to that yucky slide, which is, that's scary and that's worrisome. But it leads us to the next slide, which is what we've known now for 25 years. This is the first and the biggest study that was done looking at what diabetes control does for altering the outcome of patients with diabetes. So this is talking about all patients with diabetes now. And what we know is that just a 60% reduction in your average blood sugar, so taking your average blood sugar down by 60 points over the course of a 10-year study led to a greater than 60% reduction in the eye disease and the kidney disease seen in patients with diabetes. So what we know from many years of data now is that virtually all the complications of diabetes are preventable by normal blood sugar control. So this is a disease that is completely treatable and completely preventable, although not curable yet, but hopefully in the not too distant future. In fact, what I didn't talk about because of time limits is we now have those pumps and those sensors that automatically can talk to each other. And we've had children who have gone for 3 weeks with totally normal blood sugars without any human intervention, just by the sensor saying what the blood sugar is, feeding the information to a laptop, that laptop feeding the information to the pump, and the pump giving the insulin. So we're getting pretty close to an artificial pancreas, totally external, but they have internal pumps and internal sensors as well. So the future is exciting for how we manage diabetes, and that will be the same for cystic fibrosis-related diabetes. So in conclusion, CF is a multi-system disease that affects the lung, GI tract, but there are major endocrine complications. CFRD is the most common comorbidity that is seen in CF patients. So it's pretty likely you're going to get involved and get to know an endocrinologist and some point in your 90, 100 years of life with cystic fibrosis. And in summary, insulin deficiency is found in most patients, and it leads to a catabolic state, and we want to block that catabolic state. We want to give the anabolic hormones. And you hear about anabolic steroids, for baseball players and whatever. Well, no anabolic steroid's more potent than insulin. So it's a great anabolic steroid. Diabetes is expected. Intensive insulin therapy reverses the issues. And most exciting, even with just the recent data, and we haven't been doing this that long, is that the gap in mortality between CF patients with and without diabetes is really narrowing. And we can all learn. My dog learned how to swim from that beaver after watching there for a while. So that's it. I'm happy to take any questions there. On time. Very unlike me.
So are there new developments where patients don't have to keep pricking themselves? Because that seems like that would...
You got it. So yes and no. Yeah, so the question is, can we get non-invasive blood sugar testing is the general question. In other words, can we avoid the finger pricks? Because that is one of the biggest pains. Although when surveys are done of people with diabetes, and we've done a lot of them, it actually turns out the biggest thing people complain about is just having to think about it and having to have a routine that's set related to diabetes. That's the #1 issue that people have. Being different is the #2 issue that kids have. And #3 is the finger pricks. So it is a big issue, these finger pricks. I've been involved in trials for over 30 years trying to find different types of ways of checking blood sugars without doing a finger prick. And there is none that are commercially acceptable right now for insulin dosing. So the sensors are available. You could wear them and you get a blood sugar every 2 to 5 minutes depending on which sensor. The problem is those have to be calibrated using finger pricks. So you have to do at least 2 finger pricks a day for any of them. Some of them require 4 finger pricks a day to calibrate it. And none of them, through FDA requirements right now, will allow you to dose insulin based on the value without correlating it to a finger stick value. So we're getting there, but we're not there. Any of you in the medical field know about pulse oximetry, where you put a little thing that shines a near-infrared light through your finger and we can measure oxygen. An interesting serendipitous story was 30 years ago, a diabetes patient was working, I think it was for the Department of Agriculture, and they were grading potatoes. And they noticed that the way they graded potatoes was looking at the sugar content versus the starch content, and it was done by shining a light, near-infrared light, through the potato to see how much sugar was in it. So that led to this panacea of developments, and I actually, 25 years ago, sat with a machine this big, put my finger in it, and it could tell me what my blood sugar was accurately by shining a light through it. And so we thought we were going to be there. It was really exciting. The problem is, it turns out it's completely dependent on the color of your skin, the temperature of your skin, and it varies throughout the day. So although we have the technology, when it comes to the details of getting it accurate enough so that we could give insulin. Remember, the problem is, if you give the wrong dose of insulin, it's life-threatening. So we have a whole bunch of tests that are accurate to 1% or 0.1% with regards to glucose checking. And we think, well, that's great. The problem is if you're checking 1,000 blood sugars a day and 1 out of every 1,000 is abnormal and that's life-threatening, it's no good. So the problem is we're still stuck with something that needs virtually 100% accuracy. And that's the limiting fact. But we're working on it, but we're not there.
I know you had touched on this earlier, but are there certain strains of CF that are more related to CF-related diabetes?
Right.
How does that work?
So the question was, are there certain types of CF that are more associated? And yes, the one that's best described is the delta 508 mutation, which is the most common mutation. If you're homozygote, meaning if you have 2 of those genes, you have a significant increased risk of developing diabetes. If you're heterozygote, it's lower, and if you don't have that defect. But it hasn't been looked at probably 950 of the other mutations that are known. So, but that's one. So it does seem to be correlated. Anything else? Well, thank you. I guess we get to see who the special guest is.